just had an all-round idea of how to go about with respect to diagnosis and treatment. Now I'm going to, in session 2, concentrate on one of the important parameter uh, or a condition which very closely mimics failure, that is immune reconstitution inflammatory syndrome or paradoxical reaction, or IRIS as it is called. Now there are potential benefits and risks of starting ART immediately with TB treatment. Now because the benefits outweigh the risk as per ACTG 53T1, we were able to dogmatically state that we have to start ART as early as possible. And that being the case, you are going to see more of immune reconstitution inflammatory syndrome on one hand. On the other hand, because we have this test and treat policy by NACO, we are going to start patients on higher CD4, so probably immune reconstitution inflammatory syndrome can come down also. So it is time which can actually say whether we want to adjust our timing of ART between the 2 weeks to 2 months. If you look at the benefits, the direct benefit is reduced morbidity and mortality. All your neuropathies due to HIV, all your pathies will come down. Most importantly, we have improved TB outcome. As I told that if it's extended beyond a particular point, even with ART, the CD4 doesn't rise. So we have to start ART as early as possible before the virus starts dictating its claim. But one of the most common factors or one of the most common syndromes which we come across when you are treating patients is immune reconstitution inflammatory syndrome. The second one is cumulative toxicity and combined toxicity due to ATT and ART. Drug interactions are nothing but because we have to use these drugs simultaneously. It's quite inevitable that we have to face this and we have to properly manage them. Pill burden, of course, it has been brought down by single pill by ART, so pill burden has actually been reduced to a great extent. Coming to the START trial, which showed us 57% reduction at immediate initiation, WHO immediately said that you please start ART as early as possible, which has been immediately taken over by NACO. So TB became one condition where ART is started irrespective of CD4 count, and it has to be started as early as possible and immediately after the patient is able to tolerate ATT. So this is how our test and treat policy has helped in not only reducing the morbidity and mortality related to TB, but it has helped to prevent other opportunistic infections also occurring simultaneously. Looking at the drug interactions, you know that most of these drugs are acted upon by the cytochrome P450 system, where you can see that the protease inhibitors, the NNRTAs, all of them are actually getting into problems when you are administering rifampicin and other drugs which can actually increase the metabolism in the liver. So this is important because rifampicin can reduce the therapeutic dose, and subtherapeutic levels of ART can cause problems with resistance emerging. Even if the newer drugs, bedaquiline, strangely, bedaquiline concentration is increased by efavirenz and decreased by PIs. So it is not a preferred drug of choice in HIV, so you switch over to either delamanid or a nevirapine based regimen. Rifabutin has a lesser action on the CYP3A4 enzyme and hence can be used as an efficient alternative to rifampicin. Either can be given 300 mg thrice weekly or 50 mg daily. If a patient mandates protease inhibitors, especially due to virological failure or in second line therapy. The same rifabutin can be replaced with rifampicin because MAC, you don't have to change regimen too much, but you give a regimen of rifabutin ethambutol with one of the azides, clarithromycin or azithromycin, to tide over the crisis. And once the ART increases the CD4, MAC can be treated. And the good news is that MAC in HIV is much more amenable to treatment than MAC in non-HIV. This is something strange. Now coming to immune reconstitution inflammatory syndrome, what is this? It is the predestined fury of the perturbed immunity. That's what I usually call it. It's called by various names. You call it as immune restitution syndrome, you call it as paradoxical reaction, and there are various types. One is unmasking IRIS, where you have you don't know that the patient has got TB. When you start putting the patient on ART, suddenly the TB creeps out. It could be anywhere in the body, it can be in the brain, it can be in the, and depending on the situation, it can be disastrous. Paradoxical IRIS is something which is very easier to diagnose because patients who are treated on TB treatment, they actually have a partial response to treatment, they become all right, but after ART, they paradoxically become worse. Now, this is something which is not difficult for us to find out clinically if you are closely watching the patient. Cryptic iris are otherwise called radiological iris, where the X-rays can show a flare-up of lesions where the patient is totally asymptomatic or has very minimal symptoms. Autoimmune iris is not very uncommon in TB itself. We call Ponson's syndrome, where the patient develops autoimmune arthritis when treated for TB. So these things are quite common and they are exaggerated in HIV. Now, what do we need to know about iris? It can occur even without immunocompromisation. The most important thing is that you can see that patients with X-rays, what we have seen over the years in NIRT itself, that X-rays do worsen during the 15 days to 1 month of treatment. So that is why it's sometimes very difficult to understand, but the patients symptomatically are doing well. But HIV exacerbates this condition. The other thing is it is not very specific to any organism or ART. So it can occur with now in HIV, not only with TB, it can occur with PCP, it can occur with toxo. That's why in PCP and toxo there's absolute contraindication to start ART. You have to treat the patient for PCP, treat the patient for toxo before you are starting ART. The same for TB, you have to give a permissive delay. I will come to that. Doesn't require any treatment change if it's proved to be a paradoxical type. And it is not unique to the immunodeficiency occurring in HIV alone. Any patients on long-term steroids, some other autoimmune disease which causes, let's say, a congenital immunodeficiency, transplant patients, all of them, when they restitute their immunity, they can develop this kind of a paradoxical reaction. Now, this is our own paper which showed that there is a lot of hype on IL-6, especially in the COVID era. What we found was those patients who had advanced HIV in the form of reduced hemoglobin, reduced HCT, increased viral load, and then very much reduced CD4 and CD4-CD8 ratio. Now, all of these patients are prone for developing iris, apart from patients who have disseminated TB, which is evidence in the form of an extrapulmonary lesion along with the pulmonary lesion. This we published in 2013. We unraveled the mystery of iris. What we found was, you can see that the blue and the red dots. The blue ones are those patients who did not develop iris, whereas the red ones are those patients who developed iris. We wanted to know if we can predict iris, like a magician or an astrologer. We can say that yes, this patient will go in for deterioration. So what we did was we looked at the types of cells which are causing them. We found that peculiarly the monocytes actually reduced in the patients with iris compared to those without iris. Monocytes were the culprits which actually led to the increase in IL-6. You can see here that there is a logarithmic increase in IL-6 compared to the patients who are not developing iris. So those patients who develop iris had a logarithmic increase in IL-6, and please understand this is a logarithmic scale. So what I mean to say is that the increase in IL-6 levels are much more larger than what you perceive in this diagram, and the downstream mediator of IL-6 is your CRP. So that is how the IL-6 goes to the liver and stimulates the CRP production. So this is something what we unraveled in iris, and we had published enough papers in iris, but the most important points to remember is iris has got nothing to do with TB outcomes. So if the patient is started on steroids in between or anything, we found that doesn't have a long-term effect on TB outcomes. There were some reports of increased recurrences of TB, but we have not come across this increased or predisposition to TB recurrence later in those patients who develop iris. That is point number one. The other clinical point is we were looking at the leukotriene A4 hydroxylase enzyme. The polymorphism was said to be very, very important in dictating terms with respect to steroid administration. We found that all these patients, whatever polymorphism occurs in the LTA4H genomes loci, we found that it's amenable to steroids. The most important point is if the wild type is actually replaced by a mutant type, we found that the severity of iris was much more in these cases. Now coming into deeper thing, it is not that there will be a why do you think tocilizumab did not work properly or was working in a very selected group in COVID? Because cytokines are pleomorphic as well as redundant. One cytokine can have multiple functions, whereas multiple cytokines have the same function. So it is not just monocytes. What we found out was a particular set of monocytes are alone involved in iris. This, when we fractionated further into what is happening with respect to the immune system, we were able to understand the marvel of immune system in our body. What we found out was in those patients who did not develop iris, the naive cells were increased. But whereas in those patients who had iris, it was the effector memory cells who increased, and especially with these two CXCR plus and CCR minus in the CD4 lymphocyte, they were targeting, they were the crusaders for creating an immune reaction. So the treatment of iris, whether it's COVID or TB, it's steroids play the main role, and it's not currently under, others are actually under research where we want to go very specifically into IL-6 agonists, antagonists, or whatever cytokine antagonist. We are still not in the fray. It's a long way to go still further. Very rarely you may have to withdraw ART, as in the case of tuberculosis or pericardial effusion, where they can cause tamponade, or it can cause spacewalk lesion leading to increased intracranial tension. If patients need steroids, we also found out that in TB iris, especially in HIV, low dose steroids, the usual recommended is 2 mg per kg body weight, but even 0.5 to 1 mg per kg body weight was good enough, and it was easier for us to taper. So looking into that, if somebody is becoming steroid dependent, you can also use thalidomide. Of course, you know the problems of thalidomide, so we have to be really careful in patients with in pregnant women, because it can cause phocomelia. Montelukast and Merovirok and all other drugs have been found to be not effective in curbing iris. Looking at the prevention, most importantly, you have to screen for other opportunistic infections. The other thing is a permissive delay. What we found was a permissive delay of up to 1 month among patients with CD4 of more than 100 or 150 reduces the incidence of iris without causing any compromise on survival nor on the emergence of new opportunistic infection. So this is something which is which we have data on that, but this requires further exploration. Looking into preventive TB therapy in HIV, preventive therapy has come a long way, especially with our goal of NTEP or TB elimination by 2025. So there are various regimens, the most popular being INH. Of course, you know the peripheral neuropathy is already a complication in HIV per se, so you have to be really careful when you are giving. You have to always give it pyridoxine. Newer regimens with shorter duration of treatment as well as once weekly therapy has gained popularity, like the 3HP regimen. Again, the use of rifampicin, it is for time to tell us whether there is any acquired rifampicin resistance or rifamycin resistance occurring with it. But as of now, it has been very successful in helping us, and also as a regimen which can be easily implemented in the program. Cotrimoxazole therapy is very important till the patient restitutes his CD4 to a particular level. Of course, you have to be very careful with patients who have already allergy to sulfur, and also patients may develop neutropenia, which you have to be careful about, and especially when the body weight is quite low. So the key messages are that HIV complicates every aspect of TB. Daily regimen is superior in terms of efficacy. Immune recurrent inflammatory syndrome is a very common syndrome. It has to be differentiated from failure. The use of gene expert actually helps us, because previously when we were treating these patients, we never had the opportunity to just take to detect rifampicin resistance at an instant pace. But now that Cibinat is available, you can find out if the patient is having drug resistant TB or immune recurrent inflammatory syndrome. The reason is because the most common misdiagnosis we make in iris is drug resistant TB. Administration of steroids to drug resistant TB is like pouring oil into the fire. So that is why it has to be definitely ruled out. The most easily and the most definite way of diagnosing iris is a 1 log reduction in viral load, and the patient is having response shows initial response to ATT. What I mean to say is, if the patient's initial viral load was 40,000, it should reduce to 4,000. If it's 4,000, reduce to 400. In such a situation, we think in terms of iris. Especially in pulmonary TB, it's very easy, because your smears are positive initially, your smears are negative. Only the patient it's an apparent worsening of symptoms and signs rather than an actual worsening of signs and symptoms. Drug-drug interactions, as I told you, require modifications of both drugs. This juggling is very, very important for us to see to that the therapeutic levels are maintained in both the diseases. Thank you very much.